so much. So as Jeff said, I have mostly a clinical hat on. I'm a psychiatrist, and I have been developing this passion ever since I was in my early years of residency, noticing that the type of medication that we prescribe to patients with very similar symptoms depended on the doctor who was, supervising me. So sometimes it was medication A, sometimes it was medication B, and they were quite different medications sometimes. And I wondered, what is the rationale? So, and I felt like it was still kind of the trial and error approach that was used and personal experiences, but it wasn't really about the personal medicine for the patient. It was really just about maybe what the physicians felt, what the physicians, the prescribers felt good because they are either have experiences in one domain or in one era of medicine or so than others. So this is what triggered me, and then I heard about the genetics, and I was very interested. I already was doing some genetic work back then. So this is how I got into this field of pharmacogenetics and psychiatry. And I would say that I was really very early on a proponent, and I had probably implemented the first with our team here at CAMH. We were among the first in Canada and maybe worldwide to use pharmacogenetic testing for our patients, and it was quite a challenge. And there were a lot of mild roadblocks, if you wish, about how to consent and how to take care of genetic data, which is quite sensitive. So I'm very proud that now, where I work now at this Ontario Shores Hospital, which is a standalone hospital, as I will explain in a little bit, huge hospital for mental health conditions exclusively. We're now doing pharmacogenetic testing there as part of routine clinical care, not just for research, but for routine clinical care. And that's really so rewarding. And then, when you hear cases like we will hear later from Larry, it's a very rewarding journey for me overall. And I'm hoping to share a little bit of that journey with you and to give a bit of an update where pharmacogenetics and psychiatry stands in 2026. Most of you will probably know already the basics, I'm sure, but perhaps, I can add a bit more, a bit more history or context or so if you want me to. And so going to the first slide. So this, I don't need to explain this to pharmacists, right? We are having the pharmacokinetics and pharmacodynamic compartment. We're still there today using exclusively pharmacokinetic markers for pharmacogenic testing. The neurotransmitter are still work in progress. With the exception, of the HLA and HLA-B gene, as we will see in a moment, for hypersensitivity, but otherwise it all remains still in the domain of pharmacokinetics. And of course, we're aware that there are other factors that we'd like to include, particularly phenoconversion is an important one, right? So I'm not telling you something new, but I just wanted to make sure that we are here on the same page. In fact, this pharmacokinetic drug enzyme or the drug metabolizing enzymes, the interesting things about this is a little bit that the proportion of psychotropic medication metabolized by individual enzymes is quite tipped towards CYP2D6, CYP2C19, which are both highly genetically variable. But CYP2D6 in terms of quantity is relatively rare, so to speak. I think, well, rare depends. It's only about 2% of all the CYP enzymes, so this system can also get overwhelmed quicker. And let me see. Yeah, this is, I think, clear now, right? And then we have ultra-rapid metabolizers, known metabolizers, intermediate and poor metabolizers that we typically characterize. And this is just an older study that you can see here, which pretty much actually let us understand in retrospect why people would have different plasma levels without blaming them for maybe over-reporting side effects if they are poor metabolizers, or maybe blaming them for non-compliance if they have no plasma level like this individual in the blue there, because they're just simply not metabolizing medication as most people would, right? So I think it's also a very important tool, for example, in forensic psychiatry, right? When people need to adhere to treatment, in order to get passes, in order maybe to get released from psychiatric hospitals. If they don't do the genetic test, they might be blamed for non-compliance or will maybe not get a chance to leave the psychiatric institution. And as you know, genetic analysis can nicely characterize these 4 types, particularly for 2D6 and 2C19. I think we're quite good there yet. And now, what does it mean clinically? So this is a study, for example, from a Danish patient cohort, because as you might know, in Denmark, they have these nice longitudinal prospective data sets. And they looked retrospectively, so the people at that time who were admitted, for example, to emergency rooms were not aware of their genotypes, right? So, but you can see that basically, about 2D6 and 2C19, that obviously there is a higher risk of, for example, having suicide attempts or switching the medication more often if you're poor metabolizer 2C19. Younger adults also have a higher chance of switching or needed to switch medications. And young adults with CYP2D6 poor metabolizers using fluoxetine had a higher chance of needing to get to the emergency department. So this is very kind of consistent with the notion that outliers from a genetic point of view or from a plasma level metabolism point of view will have a more troubled journey during their pharmacological treatment. Okay, good. Then currently, I think we can convene, the experts and whatnot, and with you, Jeff, and with Chad, and with Kelly Cottle from CPIC, and so on, that we probably have now 7 genes that we would like to have on a panel. And the reasons are here because they metabolize medications involved in psychiatric conditions. And currently, that's also the 7 genes that we focus on our implementation service in our hospital. Nonetheless, we also have the other genes tested for in case patients also need maybe some other medications like a statin or a proton pump inhibitor. But that's really the focus. And I learned that for us psychiatrists, you should not give out more information than for those 7 genes primarily, because otherwise you overwhelm the prescribers and they feel like there's too much here going on. You're just confusing me, Daniel. So they will they really benefit from an overview summary like this one here, and then a recommendation which clearly says consider something else or consider something higher or lower. But that's really one of my experiences that I did got over the years. Here, what I found interesting about this study was it's a study where people were giving risperidone or aripiprazole in a Scandinavian cohort. And it was interesting. On the left side, you see in retrospect what people were getting in terms of dose of risperidone. And it's interesting to see that the poor metabolizers were on average getting lower doses of risperidone than the ultra-rapid metabolizers. So in a way, doctors or prescribers, even without knowing the genotype, they kind of found out that you might need to stop earlier for some patients who then turn to be poor metabolizers, and then you might need to go higher for medication in retrospect to see, they're actually fast metabolizers. Now you can see that, or you can think that adjusting the dose is then all you need to do, right? And the next graph, however, tells us a bit of a different story. Despite that compensation, ultra-rapid metabolizers and poor metabolizers were the ones who were more likely to be, were more likely to be switched off the medication, who were put on another medication, maybe brexpiprazole, maybe, I don't know. But ultimately, it does not seem to just be a dose adjustment, provided that the dose adjustment here was adequate, but if it was adequate, so for example, rapid metabolizers gets maybe a milligram more on average, and so on, that tells us something interesting, that it's not just about dose adjustment. And then, this U-shaped curve, I like to call it the U-shaped curve. We see this in other studies as well. For the sake of time, I'm not going to list them all, but we often see that the outliers just need more trials. even if, compensated in this case for those effects. So what are the genes actually that are listed? Well, here are the genes that are listed earlier before, and there are a few other genes here in our recommendation consensus guidelines. It's because simply we included them sometimes to show also what is not available. For example, for COMT, everyone's asked always about what about COMT, and this guideline on opioids, for example, was specifically including COMT to highlight that there was no real reason to include COMT at this point of time in opioid use disorders. The antipsychotic one, Jeff, that's one of the highlights, I think, that this guideline is on its way, right? Almost submitted, right? And that's huge because, I can't tell you how much the field has been awaiting that guideline, to complete basically the core psychiatric medications. Okay, and here is one example. And I want to highlight this again here. You see also the serotonin transporter, which is the SLC6A4, and the serotonin 2A. These people here, and I happen to be one of them, we looked at those genes very carefully, and we only really came up at the end with recommendations for 2C19 and 2D6, and to some extent to B6. But ultimately, maybe there is something there for the serotonin transporter, but we don't have the convincing data yet. Or maybe we haven't found the method yet how to maybe correct for confounding factors, but we're not recommending it. But what is interesting here, again, you remember the U-shaped curve about the poor metabolizers and the ultra-rapid metabolizers who now are more likely to get in trouble, right? There's a strong recommendation here, for example, for citalopram or escitalopram, that if you're ultra-rapid metabolizer or poor metabolizers, it's really just more or less a don't do it rather than just adjust the dose, right? Now, if you still, as the prescriber, are still convinced for some reason that the medication should be given nonetheless because it may have worked well in the past, there is, of course, also unknown variables that might that might still work. But ultimately, keep in mind, not just dosing, better stay off escitalopram if someone is poor metabolizer or ultra-rapid metabolizer. And there are alternatives, right? Particularly in that case where, since alternatives are available, it would make sense to just not even go that way. And we have the Canadian clinical guidelines. Now, I was also invited, and this is the group of psychiatrists across Canada who are regularly giving out guidelines about how to treat depression, for example, right? I think here it is, right? So you can see these are all famous psychiatrists, at least north of your border or north of our border, north of your countries, and north of your states. And, I battle with them regularly. I battle with them regularly because they say it's not ready yet to do pharmacogenetic testing in, at a population level. And I say, well, maybe not on population level, yes, because many people are known metabolizers, so they will not directly benefit, in case they get standard medication at standard dose. But do you have the outliers? And so I battle with them back and forth, and eventually we kind of, left the box ring with this kind of compromise. Pharmacogenetic testing might be useful in some clinical situations, right, where there's poor response or side effects, which leaves the door open. You can still do it for individuals, maybe. But I think the global genetic testing is just seen as too much disruptive at this point of time, and also expensive, right? So if a test costs, I don't know, $300, $400, $500 US maybe right now, doing it for the whole population is a nice thing to have, but it's probably a bit unrealistic still. So that's where we are. And then there's also this notion about populations that I like to stress with people. I'd say, well, yes, maybe pharmacogenetic testing might not be as important in Europeans potentially for CYP2C19 poor metabolizers, but what about the East Asians, Oceanian populations, right? And that's where they kind of realize, oh yeah, you're right, and different populations also need to be included. So that's the best compromise I can come up with. When we do the next guideline, I might be able to fight a bit more and to get a bit more support, but that's very much, currently the standard, I would say. Also in the US, there are typically that kind of summary. Well, in distinct cases, yes, why not? But at a population level, who's going to who's going to pay for it. Insurance companies probably are not convinced to pay for everyone right now. So that's where we are, right? And exactly, this is a bit what I was just saying, percentage-wise, if you talk about the outliers, they're not as many, right? And that's, I think, what has slowed down the implementation process for 2D6 in this case, in Europeans at least, right? So people, 5 to 10% are typically, the population. But I will argue that this is just might not be true in tertiary care centers like specialized clinics, because they are more likely to see ultra or poor metabolizers because people have been referred only if they fail medications to us. And then I would like to remember that this is a nice small study from a German group, and they have looked at actually how many people are really known metabolizers for both 2D6 and 2C19. This is mostly Europeans, and actually this is a very consistent number. Only 3% are really normal metabolizers for both gene at the same time. So there's always someone who's maybe intermediate and something else, right, as you can imagine. But that's really also something I think to push against a bit. Like most people are just not normal metabolizers. Most people have some gene variants that are actionable, be it alone just 2D6 and 2C19. And then there are others, of course. Yeah, so when I started this work now in Terra Shores in 2024, I was literally hired to implement pharmacogenetics because they saw the value there. As in Terra Shores, we have like very severely ill patients with psychosis, and we serve a large outpatient community for difficult to treat depression, anxiety, and so on. So this is a bit the numbers here. So 350 beds is quite large. So basically, second largest mental health hospital, I believe, in Canada. And now this is a nice thing. This always makes my day if I open the medical records, and I see now there's a tab there, genomics. I can look up everything or implement or include, anything, including the genomics, right? You see how nice it is, right? Smoking history is important for 1A2, right? Capacities and consent. Can patient go out? Do they need permission, passes from others, maybe from substitute decision makers? And what about the genomics, right? So we're really, I think, breaking new grounds here in our Meditech system. And here I'm going to show you real data. This is just this week, basically. We did a breakdown of people who have been, diagnosed with problematic, so to speak, genetic variants, and those are highlighted in this red squares, right? So and you can see the numbers, are quite substantial. So it's not really just the outliers who have, I wouldn't call these outliers anymore if I see so many individuals having gene variants, and sometimes of them, of course, the same individual has these deviant, maybe we can call that, gene variants. And so we're still chewing on this data. What, unfortunately, I don't have ready now, because I was hoping I had the surveys by today, because we send out surveys to physicians and patients to give a bit also more the patient story, today, which was actually one of the topics, right? But I'll show you something else instead, and then we will have, of course, Larry after me speaking, maybe like in 5 minutes or so. So here is a study from England, London, I believe, and there were like, sorry, no, this is not yet it. Excuse me, this is my website. Sorry, I have one patient story, or I've, among Larry, among others with Larry. This is a patient story that I found very interesting, because that patient came to me after she lived many years in Australia, and in Australia she was taking agomelatine at the end because nothing else worked. And now she came to Canada, and agomelatine is not approved. It's a melatonin agonist, right? So I kind of debated with her that maybe she would try this venlafaxine, because I did not know the genotype at that time. I wanted to make a quick decision for her because she was suffering, and I prescribed this venlafaxine, which is inert to 2D6 and 2C19, and she does wonderfully on that medication. And so she. And then the genotypes came in and they confirmed she was deviant in terms of their genotype. So very powerful story. And then she wrote me this nice words. And I find this is, the heart-wrenching piece is really when they say, when patients say to you, if there it had been done years ago, it could have been saved me a decade of time and suffering, right? So think of the journeys that many people are going through. They lose hope in medication. They don't want to see a doctor anymore. They may try something else now. But a genetic test would have literally, quote unquote, rescued their journey. So that was a nice story. Now I'm coming to the UK study, excuse me. So this is a study done in the UK where they had this program called GEMS, Genetic Environment in Mental Health Studies. And it's a small study cohort completed by 22 patients and 11 clinician participants. And here are the citations, and I find them interestingly because they're very representative. I had heard these same things over and over again. So these I don't know, 8 quotes or 9 quotes that I have here, they have been most of the time feedback. I was curious. I've been on various types of drugs, and none of them have really helped, right? That's obvious. I have had much success with medication, so the study intrigued me. There are also people who say, hey, I just want to find out for myself what's, again, what might be the genetic component. Then 3 patients also just wanted to support research. They said, I want to give back to the institution, which is often also a reason why people eventually buy into our research studies. And a clinician here said also that's pretty much what I hear all the time. No one is really harmed. No one has reported negative outcomes, or no one has been deteriorated after genetic testing. So this is important because these tests are typically not harmful. And then we have patients curious to try to understand about their enzymes and about what's happening in their body. It's kind of empowerment also. And then we've had comments, or we can see comments like, however, this is what I mentioned earlier. The report needs to be easy, understandable, and could be more user friendly. People shy away if we overwhelm them with complexity, even if we mean it well, because we're academics. We want to make sure that we have everything there. But for the real world, that's not always the best. And then, there's also frustrations once you do a pharmacogenetic test. Some people say, wow, you had no idea before that, and you were giving me, and you wanted to give me something that you don't know if I would even tolerate it. How scientific is this, So, there's also a bit of eye-opening moments for patients sometimes about that. And, and then here's again the same that I just read earlier, right, from my own patient. It could have saved me years, after having spent 16 years on several less suitable medications, right? So this is really rewarding, but in a way also heart-wrenching that people have gone through such journeys. I think this is the last one. Can read it because the bar is there. Okay, one patient recalled thinking that the medication failure is just in your head, but the pharmacogenetics report demonstrates in black and white why they were not working. I find this also beautiful because in psychiatry, as you have no objective measures. There's no blood level like in diabetes or so, where you measure blood sugars. So, patients' symptoms can fluctuate. They can be subjective, so sometimes they also think that they might just not respond because it's them, they feel guilty maybe. They want to report that they do better. So they kind of imagine it's maybe my head, I'm actually doing better. It's just that I'm too pessimistic. But sometimes it's really not just that. It's really just the genetics that didn't work, right? So that's important too for them. Good. By the way, the report said early on, that the term patient in psychiatry is a little bit like, under discussion right now. Some people don't like being called patients because they, once they're treated and they're doing better, they're normal people again. And now we call them still patients, and that's a little bit where we should ask our population what they feel most comfortable with. And in this study, it said that, that people were more happy to be called patient other than the alternative, which could be people with lived experiences. So if you're interested in psychiatric pharmacogenetics, I can offer you to email me, and I'm trying to get things organized here such that we have a small network that can do webinars and so on. I would be particularly pleased if someone would also maybe help me here in navigating and keeping track of these activities. So please feel free to email me. And we have currently a network of maybe 275 participants or something across the world. So this is where we want to bundle, people particularly interested in pharmacogenetics in psychiatry. And with that, I think I'm coming to the end. This is my research team. I would not like to miss to acknowledge the team behind and the colleagues and next to my offices who are kind of supportive. If I have questions about the lab or if I want to know the latest updates on epigenetics, we have all these experts here, which is great. So that's why I like to acknowledge them. And with that, I come to the last slide. I think, no, I come to the end. There's not even a questions or thank you slide, so I will say it in words. Thank you. And please let me know if you have any questions.